Greetings, everyone. So today's discussion will be on a white lesion on the tongue. Usually we say this as white lesions, and we will discuss differential diagnosis. This will be adding to the knowledge packet of therapeutic guidelines just read in the last session. And we will go through causes of white patches. And this case is case number 45 from ODELL. And let's proceed with this one. Its heading says that a white patch on the tongue. So this is a 52-year-old woman, has a white patch on her tongue, make a diagnosis and decide on appropriate treatment. Patient has no complaint about this lesion. You as a dentist have noticed this lesion in a patient attending for the first time in several years. There is no written record of the white patch in her notes. The patient had noticed the lesion but had ignored it. So it's not a painful lesion, and as she is ignoring it, she thinks it has probably been there for several years. So it is a long-standing several years lesion. This should alarm you to take biopsy. A lesion existing in the high-risk area, the tongue, ventral surface, floor of the mouth are the high-risk areas. Now, the patient is otherwise fit and well. She smokes 4 cigarettes a day and drinks 4 to 8 units of alcohol each week. So for all the oral lesions, overall, we need to have the medical history and the social history of drinking and smoking. But it is far more important if we have a long-standing lesion. No lymph nodes are palpable in the neck, and there are no abnormal findings on extraoral examination. So lymph nodes palpability is important in these cases, because if it is red flag lesions, it is turned malignant or anything, we would find maybe lymph node involvement. So far, this doesn't exist here. Then we have intraoral examination. Apart from this lesion, remainder of her oral mucosa is normal. So intraoral is gone through fine. Now, even they should have mentioned about any such lesions present on the body anywhere else. So if you are doing a history taking, you would ask that anywhere else in your body, do you have any patches or any lesions, which you worth mentioning. Appearance is as shown in this picture, a flat and homogeneous white patch on the left lateral border and ventral tongue mucosa. It is well defined and varies slightly in whiteness. If you were to able to feel the lesion, you would find that it is soft and feels no different from the surrounding mucosa. So it's not a frictional keratosis, which would be up and raised, and it is soft, no difference from the surrounding mucosa. It's just merging in, blending in. What are the common or important white patches in the mouth and how they are caused? So almost all oral white patches are caused by increased keratinization of epithelia. Keratin absorbs water and appears white, and it is brighter white where it is thicker. So the thicker the area, it is brighter white there. The exception is a chemical burn where the white surface layer is caused by necrosis or ulceration. Common and important causes of oral mucosal white patches are given in the table. So you have to remember this table for differential diagnosis for white patches and correlate to any clinical pictures which comes in appearance or which comes in exams. Now, normal mucosal variants, leukoedema, Fordyce granules are normal mucosal variants, physiological variations. Inherited epithelial disorders, white sponge nevus, Pachyonychia congenita. These are epithelial disorders, they are inherited. So this would reveal itself, you would have to elicit it in the history, prenatal, natal history, and the genetic history of the person. Traumatic lesions. So frictional keratosis, a constant, restoration, which is not smooth, which is again and again torturing the tongue over there. cheek and tongue biting, a chemical burn, all these are traumatic lesions. Then we have infections. Thrush, acute hyperplastic candidiasis, chronic hyperplastic candidiasis like candidal leukoplakia, and chronic mucocutaneous candidiasis, hairy leukoplakia, and syphilitic leukoplakia. These are all infections. So with traumatic lesions, you would have to associate with any clinical finding. You would have to ask patient any trauma or bite or anything which is rubbing you against, which is leading you to this lesion. And also it will be synonymous, analogous to the timeline with which that traumatic lesion happened. Likewise, this infection, you would have some idea about immune status of the patient to have any of these. All these are in immunocompromised patients. Thrush, candidiasis also, candidal leukoplakia also, hairy leukoplakia, syphilitic leukoplakia. You have associated medical history working for you. Okay, just give me a minute.
Okay.
So we will do a next session on a lesion, which are white patch on the lesion. This will add to our knowledge, which we had from the therapeutic guidelines chapter. And the learning outcomes for this topic would be all the white lesions found in the oral cavity. So let's proceed with this case from ODELL, a white patch on the tongue, which is case number 45. In this, a 52-year-old woman has a white patch on her tongue. Make a diagnosis and decide on appropriate treatment. Patient has no complaint. That means it's painless, not giving her any irritability, burning sensation, or anything. She has no complaint whatsoever. You'd have noticed this lesion. You as a dentist have noticed this lesion in a patient attending for the first time in several years. So not an active dental attendee. There is no written record of the white patch in her notes. The patient had noticed the lesion but had ignored it. Again, the indication that this is painless. She thinks that it has probably been there for several years. A very highlighting point for this lesion being there for several years, it's actually a red flag lesion. Any lesion more than 14 days and the patient ignoring it is a red flag. Medical history, patient is otherwise fit and well. And here they have given social history along with medical. Smokes 4 cigarettes a day, drinks 4 to 8 units of alcohol each week. This social history is far more important for all the white lesion cases because they can turn metastatic, dysplastic, and this is important information for that. Examination. Extraoral examination. No lymph nodes are palpable in the neck and there are no abnormal findings on external examination. So lymph node examination is a crucial thing again in the white lesions, red and white lesions of the oral cavity, because if they turn metastatic and lymph node involvement happens, we have to test for it. So TNM staging, tumor nodes and metastasis. So this is an important information again to be checked in white and red lesions, patches in oral cavity. On intraoral examination, we find that apart from this lesion, the remainder of the oral mucosa is normal. So other areas of the oral cavity are healthy. Then we find appearance of this lesion. There is a flat and homogeneous white patch on the left lateral border and the ventral tongue mucosa. It is well defined and varies slightly in whiteness. If you were able to feel the lesion, you would find that it is soft and feels no different from surrounding mucosa. So it is, it's like merging in, blending in with the surrounding mucosa. It's good in the thing that it is not ulcerated, which is becoming the surface involvement and ulceration of a long-standing lesion, breakage of the mucosa and underlying connective tissue can signal cancer. Also, if it is indurated, that is becoming hard or going deep-seated and hardening that area, it again is an indication of cancer. So for this stage, it is soft and feels no different from surrounding mucosa. Now we will read the most important part of this case, which are causes of white patches in the mouth. Okay, what are the common or important white patches in the mouth and how they are caused? So almost all white patches are caused by increased keratinization of epithelium. Keratin absorbs water and appears white, and it is brighter white where it is thicker. Thicker the lesion, whiter it is. Exception is the chemical burn, which is also white, but here the white surface layer is caused by necrosis or ulceration. It's the charring of the tissue, the slough formation, which will give the appearance of the white. Now, what are the commonest white patches in the mouth? First is the normal mucosal variants, which are leukoedema, fordyce spots, and granules. So this is the physiological variation. Absolutely normal. Then we have inherited epithelial disorders, white sponge nevus and pachyonychia congenita. Now, these inherited epithelial disorders actually are, you would have an indication from the genetic history, prenatal history, from the parents' history. So if any significant history of transmission from generation to generation is there, that would be a differentiating factor. Traumatic lesions, frictional keratosis, cheek and tongue biting, chemical burn. So all white patches are caused by increased keratinization. So constant ruggedness by, say, a broken margin of the restoration, a wire in the orthodontic or a bracket causing constant friction can lead to this frictional keratosis of the mucosa. Cheek and tongue biting, again, the same thing, again happening constantly in some patients that they will find. You can find a frictional keratosis there or chemical burn. Now, this chemical burn is actually because the white surface layer is caused by necrosis or ulceration, but it is a trauma. It is coming under trauma also. Whereas first and second, frictional keratosis and cheek and tongue biting, the mechanism, pathogenesis is increased keratinization, and here it is slough. However, both fall in category of traumatic lesions. Then we have infections, thrush, acute hyperplastic candidiasis, chronic hyperplastic candidiasis, candidal leukoplakia, chronic mucocutaneous candidiasis, hairy leukoplakia, and syphilitic leukoplakia. So all these infections are basically in immunocompromised states. So most of them are, all these are basically in immunocompromised, and it would be, you would have to link with the patient's medical history. Then we have lichen planus and similar conditions. So lichen planus, lichenoid reaction, topical or systemic, lupus erythematosus, graft versus host disease are similar, are some of the conditions which are mimicking white lesions, presenting as white lesions. Then we have something which is very interesting, type of lesion when it is written unknown, then it is called as leukoplakia. Homogeneous, verrucous, nodular, or speckled are the types of variants of leukoplakia. So when we do not have an ascertained cause, which we rule out to diagnose as any other lesion, we say it is as a white patch. We have ruled out other diagnosis, then our differential diagnosis is leukoplakia. Smoking related, smoker's keratosis, stomatitis nicotina, or which is seen on the palate, and neoplastic squamous cell carcinoma. So these are all the different types of the white patches in oral cavity. Which lesions you would include in differential diagnosis for the current lesion? So likely diagnosis can be leukoplakia, idiopathic white patch, smoker's keratosis because this patient smokes cigarettes, Less likely diagnosis would be chronic hyperplastic candidiasis, lichen planus lichenoid reaction, frictional keratosis, or squamous cell carcinoma. Now let's read each of them to know how to again sort out our diagnosis. What is leukoplakia? The literal meaning of leukoplakia is white patch. The term is correctly defined as a white patch that cannot be characterized as any other lesion. The use of this term is correct only after all possible known causes have been eliminated through whatever investigations are required, whatever associations with the history are required. So if something is genetic, it would be known from the history. If something is traumatic, it would be seen through clinical examination or asking if any feeling is hurting or broken there or anything. Unfortunately, the term leukoplakia is often used very loosely in the clinical context, either for a white patch of any cause or for small minority of white patches with the risk of malignant transformation. So our first, predilection is to term any white patch as a leukoplakia, but it is not so. When we have ruled out all diagnosis, then it's a diagnosis of exclusion. This has led to great confusion now that the term has also been incorporated into names of the several lesions for which the cause is known, like candidal leukoplakia, hairy leukoplakia, and syphilitic leukoplakia. Here it is not a leukoplakia of a original variety, inherent variety. It is caused by candida. It is caused by Epstein-Barr virus. Syphilis is caused by Treponema pallidum. So it has some agents to blame to go back to. However, the term is being quite loosely used. That's what they are trying to say. It is being used inconsistently to the point of being unhelpful. So justify your differential diagnosis, which they say is leukoplakia or idiopathic white patch, or it could be sublingual keratosis. Now, first is leukoplakia or idiopathic white patch. Although there are many groups of well-defined white patches, the largest single group is that for which no cause can be identified. This is the largest group. Still, the prevalence of this group is highest. This is therefore likely diagnosis for the present lesion because there are no clinical features that suggest any specific cause. The group of idiopathic white patches includes some more specific terms that might be applied to this lesion. So more specific terms we need to go. Leukoplakia is a generalized term, which could be sublingual keratosis. They are now specifying it to the location. It refers to white patch affecting the floor of the mouth or ventral tongue, and lesions here are considered to have high risk of malignant transformation. The typical lesion is bilateral and may be extensive in the floor of the mouth, often with a wrinkled surface of ebbing tide parallel corrugations. However, sublingual keratosis is defined only by its site. So it is only a site which is making the diagnosis specific, sublingual keratosis. But if you say it is a part of, under the umbrella of leukoplakia. And any white patch affecting ventral tongue on the floor of the mouth could be termed sublingual keratosis. So any white patch on the area can be termed sublingual keratosis. The present lesion only just extends to the ventral tongue mucosa. Smoker's keratosis. It's a white patch of no known cause and found in the mouth of a smoker. So it's associating to the habit of smoking, a social history of smoking. This type of lesion is a flat, homogeneous white patch, sometimes with a finely wrinkled surface on non-keratinized mucosa. Smoking is assumed to be the cause, although there is rarely any evidence to support this unless the lesion arises where the smoker habitually holds a pipe or a cigarette. So then it becomes a frictional keratosis, constant rubbing of that area by cigarette or pipe. The patient's lesion could be smoker's keratosis, but this is not particularly useful label and does not imply that it should be treated any differently from idiopathic white patch. Smoker's palate stomatitis nicotina is a separate condition and is discussed below. Then we have frictional keratosis. It's common along the occlusal line on edentulous alveolar ridges and on the lateral tongue and may be associated with sharp teeth or restorations, and maybe unilateral or bilateral. So there, here it is coming because of some friction. The name is itself representing it. Frictional keratosis usually merges gradually with the surrounding normal mucosa and is not as sharply defined as the present lesion. Tongue biting also causes keratosis, but the surface is often shredded, and there may be similar lesions on the buccal mucosa, usually just behind the commissure. So usually the people have the habit of biting on their cheeks. So that creates that linear line at the level of occlusion would be a signal for frictional keratosis. Unless the lesions are associated with clear evidence of habitual biting or sharp teeth, or if they resolve on removing the cause, it can be very difficult to identify them on the basis of clinical appearance. So you should have a positive habit history of biting or a friction with a broken filling or orthodontic bracket or something. Then we have chronic hyperplastic candidiasis. It causes white plaques and is sometimes called candidal leukoplakia. These lesions arise commonly on the post-commissural buccal mucosa and dorsal tongue, like behind the commissures in the buccal mucosa and dorsal, the upper flat surface of the tongue, and may be associated with red areas. These lesions are more common in smokers. Unless the site is typical, it is almost impossible to make the diagnosis clinically. Biopsy and resolution following antifungal treatment are the most useful indicators to identify these lesions. So either the biopsy will tell you, or response to antifungal treatment will definitely diagnose it as chronic hyperplastic candidiasis. Otherwise, it's difficult to know it is chronic hyperplastic candidiasis. The present lesion is not typical, but this cause cannot be confidently excluded on clinical grounds. Obviously, for candidiasis, you would find something in the medical history. The patient's immunity status, either it would be diabetic, the patient would be on steroids, patient would be on HIV positive, something would be there which would, or nutritionally compromised can lead to this. Candida has to have some cause for fungus to thrive there. Okay. Fungus won't thrive in the healthy mouths. Okay. Now we have lichen planus and lichenoid reaction. It may cause homogeneous white patches. This more unusual presentation seems to be more common in smokers, and it is not at all clear whether these so-called plaque-type lichen planus lesions are a genuine presentation of lichen planus or are induced by smoking. So this is unusual presentation, but more common in smokers. And we don't know whether these plaque-type lichen planus are a genuine presentation of the lichen planus or they are induced by smoking. To be sure of diagnosis, it is advisable to find evidence of more typical lichen planus elsewhere on the skin. So lichen planus would not be a solitary one lesion. It would be seen on the buccal mucosa, say both sides, something like that, or on the skin. So you have to find out evidence of more typical lesions of skin, buccal mucosa, and or in the form of desquamative gingivitis. There is no evidence to suggest that the current lesion is caused by lichen planus, but the plaque type cannot be completely excluded on the clinical grounds alone. Then we have the next part as squamous cell carcinoma. Now, squamous cell carcinoma diagnosis must be included for any white patch in the mouth without an identified cause. The chances of this particular lesion being malignant appear low. So, a simple looking white patch persisting for a very long time can be squamous cell carcinoma also. Also, it is in a very high risk site. It is flat, homogeneous lesion without ulceration, red areas, fleckling, or induration. The patient is a light smoker and is in the risk age group for squamous cell carcinoma, although very unlikely, this just might be carcinoma. So maybe the beginning of carcinoma looks like as smooth as this. So it depends upon the metastatic changes happening starting in the cellular level. Which white lesions have you excluded and why? So leukoedema, and patches of the Fordyce's spots, which are sebaceous glands, are normal mucosal variants that affect primarily the buccal mucosa. Leukoedema causes milky white appearance and is usually seen in those of the African descent. And Fordyce spots are sebaceous glands. They occasionally form clusters that resemble plaques but have slightly yellow appearance. And individual glands are usually visible within the lesion. Both are present from childhood and neither affects the lateral tongue. Then we have white sponge nevus pachyonychia congenita. They are examples of rare inherited conditions that cause diffuse keratosis or multiple discrete white patches on mucosa. These possibilities are excluded on the basis of localized extent of the lesion, age at onset, and absence of any skin nail abnormalities and family history. Basically, the key highlighting feature is family history. If they have to give you a clue, they will give of the positive family history. Then we have aspirin burn. Those people who have the habit of keeping the aspirin in buccal mucosa, so they get this kind of a chemical trauma. Such trauma results from application of aspirin directly to the mucosa, usually in response to toothache. Lesions are mostly in buccal sulcus and affect the mucosa on both sides of site. Like if a person is keeping on the sulcus here, so it will impact the alveolar mucosa on this side and the buccal mucosa on this side. So both sides it will happen where the tablet is kept. This is an unlike possibility and may be readily excluded through thorough direct questioning. But you have to ask this history if you are, or they would be providing you this history if in your part 2 exams, anytime a white lesion comes. Thrush affects larger areas of the mucosa. At least parts of the lesion may be wiped off and the underlying mucosa will be inflamed. So a removable white lesion is thrush. So you would be able to scrape it off and underlying bleeding points would be seen. Chronic candidiasis rather than acute candidiasis could have caused the present lesion as discussed above. Then you have hairy leukoplakia. It usually forms bilateral white lesions along the lateral border of the tongue, usually in immunosuppressed patients, although the possibility of an undiagnosed immunosuppression, particularly resulting from human immunodeficiency virus infection, cannot be excluded. So it's an immunocompromised state. Okay. The appearances are not typical of hairy leukoplakia. It would be having that hairy appearance over the tongue, blackish, which looks like hairy. Lesions remain limited to the lateral tongue in almost all cases. Then we have syphilitic leukoplakia may also be readily, the patient must have tertiary hip syphilis and the site of white patches in the dorsum of the tongue. And last, we have smoker's palate or stomatitis nicotina, and that can be excluded because it affects only the hard palate of the pipe or cigar smokers and that of heavy cigarette smokers. So these were some of the lesions we would need to find with the biopsy, these lesions actual diagnosis. Then we have, should a biopsy be performed, and explain why. So yes, as a general rule, all white lesions in the mouth require biopsy. Completely typical keratotic lichen planus and typical frictional keratosis are considered exceptions to this rule by some authorities, but this would only be acceptable if the clinician were very experienced in the diagnosis of oral white lesions. Even those with extensive experience can be misled occasionally by a carcinomatous lesion that appears to be an innocuous white patch. So we would have that case coming ahead where it looks like a white lesion, but it actually is a cancer. So reasons for performing biopsy are to exclude confirmed squamous cell carcinoma, if not malignant, to determine whether dysplasia is present. So dysplastic white lesions can also be, they are to be on a high guard, high alert mode. To identify chronic candidal infection if present, and to help identify specific conditions and causes for the lesion. Then we have, is this lesion suitable for biopsy in general dental practice? Usually here, yes, as per the ODELL UK standards, they say final decision will depend on the experience and confidence and the position of the lesion and its accessibility. However, there is no reason why the biopsy should not be performed in the general dental practice. But if you are in Australian standards, they would expect, the TG expects you to refer these patients to the specialists, oral pathologists for the biopsy. So I would at this moment share you the therapeutic guidelines where they say regarding the biopsy. So can you see this? This is a biopsy guidance from Australian Dental Council therapeutic guidelines. They say that the treating specialist, it's another white lesion on the tongue, okay, on the buccal mucosa, sorry. The treating specialist should perform the biopsy of an oral mucosal lesion. So the treating specialist should perform in rural or remote areas where a delay in specialist review is expected. Seek expert advice on biopsy technique. A punch biopsy is not appropriate. So as a general dentist, as per the ADC recommended guidelines, you cannot do biopsy by yourself. You should seek specialist, oral pathologist for the biopsy, oral medicine specialist for the biopsy, or oral surgeon, because they might be treating it if it's a cancer or something. So treating specialists should perform biopsy. But if you are in rural or remote areas and it's a red alert lesion, high red flag lesion, and if a delay in referral is expected, the patient might not visit the specialists or specialist is not available, seek expert advice on biopsy technique. So under a guidance, under experts advice, you can perform biopsy. But ideal conditions in the urban, suburban practices, you would refer. So this is the guidelines from therapeutic guidelines. Treating specialists should perform the biopsy of an oral lesion. This part is our idea. Then we are going back to the ODELL. Okay. If you perform biopsy, you are taking on yourself the responsibility of telling the patient the diagnosis, and so you may prefer to refer the patient to hospital for opinion and biopsy. So here also, you may prefer to refer for biopsy. Because if there is a bad news to be broken, you again are expected to refer the patient to the specialist who will break the bad news to the patient. Here by bad news, I mean the news of malignancy or cancer. If there is any suspicion of malignancy, the patient should be referred to a specialist center via an expedited referral pathway according to local or national protocols. Any lesion that shows clinical features suggesting malignancy should be sampled by the person or team who will manage the patient's care. So it is by the team of the specialists who would manage the care. So anyways, they are also coming to suggesting you referral is the best deal. What features of a white patch might indicate malignancy and contraindicate performing biopsy in the dental practice? Associated red areas. So whenever red areas are mixed with the white, associated red areas or speckled areas, okay? Speckling is again red areas over coming through, speckling through white. Ulceration, especially if chronic. Chronically long presence of an ulcer is a risky thing because its surface is gone. It is breaking in the epithelial lining. Induration, hardening, the tissue cells have hardened borders, okay, and it is going deep and fixed. They are cancerous, like the cells are dividing at a multiple rate and hardening that zone. Enlarged lymph nodes draining the site, lesion in a high-risk site, which is the lateral surface of the tongue, floor of the mouth. Then you have, is biopsy really necessary? Are there no less invasive tests that could help identify the lesions? So to those not experienced in oral white lesions, it may seem that immediate performance of biopsy is an excessive reaction. After all, benign lesions are so much commoner than potential malignant causes. To a degree, this is true because almost 5% of the population over 50 years have white lesions of some type. Less invasive screening tests have therefore been sought to identify the lesions that require biopsy. So you must first screen the lesion before doing biopsy according to these two techniques. One is exfoliative cytology and rush biopsy. So a sample of epithelial cells can be removed from the lesion by brushing off with a stiff bristle brush. The smear containing cells is examined by using a variety of techniques, including computer-assisted cytopathological analysis. These techniques have improved and have become more reliable, but to date have not replaced the need for biopsy. So need for biopsy is crucial. You have to send these patients, refer these patients for biopsy. Then we have toluidine blue staining. Toluidine blue, it's a stain which was described decades ago, but its use has recently been